My name is Rishab and I'm going to be refuting Ricardo's topic, which was on euthanasia, or known as assisted suicide. And his claim was that existence of medical assisted suicide being beneficial to the terminally ill. And his secondary claims were that physician assisted suicide allows the patient to be relieved of their excruciating pain. And the second one being that physician-assisted suicide has positive benefits for hospitals and medical staff. Firstly, on his first claim, when he talked about, when he talks about allowing the patient to be relieved of their excruciating pain, I thought his evidence was not able to link the existence of pain as a key motivation for terminally ill people to seek the end of their life. There was a survey that was done where patients who died after taking lethal prescriptions in Oregon and Washington, that were the first two states to legalize euthanasia, were asked to give their motivations for medically assisted suicide. And pain ranked near the bottom of a list of patients' concerns. In contrast to that, at least 90% of patients in both states were motivated by a loss of autonomy. 41% of patients in Oregon and 53% in Washington said they feared burdening the people they loved. I do understand, pain management is a key problem that's faced by some terminally ill patients, but it does have a solution. And calling out pain as a significant motivation for patients is basically like ending one's life is basically trivializing the importance of life. And then the second part is his evidence on the ICU costs did not clearly establish that most terminally ill patients have to bear these high costs. On contrary, the data from 2005 in Dartmouth Atlas of Healthcare, there was only 13.8% of descendants spent 7 or more days in the ICU during their last 6 months of life in the US, which again suggests to my counterclaim, which said advances in palliative care have usually helped terminally ill people manage their pain better. And then his second claim, which was about physician-assisted suicide has positive benefits for hospitals and medical staff. I would like to counter that by saying that legalizing physician-assisted suicide would actually set us on a slippery slope which would usually result in non-caring attitude of hospitals and medical staff towards the disabled and chronic patients, and would basically view them as a burden. Netherlands, which had permitted euthanasia in 1984, at first it was only permitted for the terminally ill who requested it, but then also it was legalized for the chronically ill, for those whose suffering was psychological, and for incompetent patients, including children. These facts also, they show how Netherlands, after legalizing doctor-assisted suicide more than 30 years ago, has become steadily more permissive on allowing medically assisted suicide for non-terminal cases as well. And that is what, when I talk about slippery slope, that is really what I'm talking about. Also, when he talks about how the cost would be reduced, I thought that it would be dangerous, as it would end up making the medical groups and facilities view patients in terms of their cost rather than them as human beings. And for some, the bottom line would basically just be dead patients cost less than live ones. Organizations like Hemlock Society, which support physician-assisted suicide, they have spread extreme views on eliminating the old and incapable who are non-productive in the society. In the book by Derek Humphrey, the first chair of Hemlock Society, in his book Freedom to Die, People's Politics and the Right to Die movement, he describes pensioners as greedy geysers eating up the nation's healthcare finances. He goes further to state doctors and hospitals should be empowered to decline patients' and families' requests for life-sustaining care if they judge their preference for life to be unreasonable. I would like to conclude my speech by stating that existence of medical assisted suicide will not only ignore the value as human beings, but also will devalue the purpose of doctors. Thank you.
All right, well, the preliminary structure is set up pretty clearly. When you get to the first of the points, though, that you're responding to, it's kind of like you go back to your own argument talking about pain and how it's not linked to the desire for physician-assisted suicide. I do think that that's a very good counterclaim in this argument. The first question, though, I had is, before you get to that, what did the advocate say about this? What evidence did they provide? If they didn't provide any evidence, then I think one of the things that you can do is contrast the information that you're providing to the absence of evidence that the advocate presents. But you did have good information on this particular point, suggesting that the vast majority of people are looking for this for issues other than pain management. There is an argument about palliative care that comes kind of after the ICU cost issue comes up, which then comes up again in the second point. So there's a little bit of trade-off there. That may be because that's what the way advocate presented that information. But I thought that the argument about palliative care needed to be up in this particular argument, and you needed some evidence on that particular point. It's mostly asserted that new palliative cares can address some of the pain issues that are going on there. And then you've got the one statistic that challenges how much they're actually using when it comes to resources, suggesting that it's relatively small number in the last days of life that are using these facilities. That's an okay piece of information. I wouldn't say it's conclusive, but it does point in the direction that maybe people are overestimating what the costs are from the terminal stages of life. On the second point, though, that kind of ties into that second point, where if there's an overestimation of how much this is, that would make a motivation for hospitals or doctors or particularly insurance providers to encourage this sort of behavior. And then I think that you give us this slippery slope argument about the Netherlands, which is not necessarily a bad argument, but I think the way you explain it needs to have a little bit more detail. If there was legislation at each step in the process, then that's a decision that people have made based on their perception of how the issues developed. If any of those changes occurred without active intervention by the policies, in other words, Gesundheit, it just became standard operating procedure. This is the way doctors treated patients. I think that would enhance your argument a little bit more, that says that this is going to devalue the way people perceive others. I do think that you've got an interesting point here about the Hemlock Society and how here's a good illustration about how they actually perceive people who are sick in the end, that they are viewed as greedy and hanging on to life unfairly and unjustly, and therefore there might be a motive on the part of some people to make this decision. I think there are a couple of other arguments that you can make here. I think the cost issue should be applicable on this point. There's a lot of reading in the presentation. You need to do a lot less of that. All right, thank you. Ricardo. No, you don't get to respond to his argument. You have to respond to somebody else's argument. 5 and plus 1, so it's like we start with 6, we'll count you down. I'm not yelling at anybody until we get to 6, and then I'm not even yelling loud enough. I need to be yelling more.